On behalf of Medical Learning Institute and SOHO, we're really grateful that you're attending this workshop today. We're going to talk about relapsed refractory CLL, SLL clinical insights, navigating novel therapy integration and sequencing considerations. And this activity is supported by an educational grant from Lilly. I'm Meghan Thompson from Memorial Sloan Kettering Cancer Center in New York City, and I have Dr. Callie Coombs from UCI Health here today. So here's our agenda for today. Today we're going to talk about the complexities of treating patients with relapsed refractory CLL, SLL. So we're going to start with some background of the CLL pathophysiology. And then we're going to talk about a couple of case studies. Dr. Coombs and I will present the cases and then discuss some treatment options. And we will look at survey questions as well that were selected by a cohort of 25 clinicians, these cases prior to this program. Then we're going to talk about some evidence for treatment considerations. We're going to highlight the multidisciplinary and interprofessional care management and AEs for relapsed CLL. And then we'll talk about some shared decision-making strategies, some examples from our clinics, and then summarize our key concepts. So let's talk a little bit about the pathophysiology, disease burden of CLL. It is the most common leukemia in the United States. It is a CD5 positive mature B-cell neoplasm, and it really is unique in that there's several different compartments that are important with this disease to remember: peripheral blood, lymph node, and the bone marrow. The median age of diagnosis, depending on the studies, around 70 to 72 years, and it is more common in men than women. It's really a heterogeneous disease where about 2/3 of patients are asymptomatic at the time of diagnosis, and it's commonly found due to lymphocytosis on labs that are performed for other reasons. There are some patients that do present with symptoms, and here I list some of the B symptoms, including fevers, drenching night sweats, and patients can also have symptomatic adenopathy and splenomegaly. So here are some definitions, and as a young clinician and when I was a fellow, I found it really helpful to kind of go back to the basics because there's a lot of terms that are thrown around in terms of CLL. But CLL is really defined if you have more than 5,000 monoclonal B cells per microliter in the peripheral blood, and you can do this diagnosis by flow cytometry. MBL, or monoclonal B-cell lymphocytosis, is a pre-malignant condition where you have these CLL clones in the peripheral blood, but you have less than 5,000 monoclonal B cells per microliter. You don't have any adenopathy, meaning enlarged adenopathy criteria, or greater than 1.5 centimeters. There's no cytopenias due to the disease itself, no splenomegaly. And there's about a 1% to 2% risk per year if you see a patient in the clinic with MBL progressing to CLL requiring treatment. Then we group these together when talking about treatment, but small lymphocytic lymphoma, you can have, this CLL clone in the peripheral blood, but it doesn't meet that quantitative criteria to be a leukemia, but you do have lymph nodes or organomegaly. And then prolymphocytic leukemia is 55% or more prolymphocytes in the peripheral blood. So this is just some basics in the clinic. So if the CLL patient is, their cancer cells are reading the textbook, this will be the typical profile. So CD5 positive, CD20 is usually expressed but typically dim, CD23 positive, CD200 positive. There can be some variation to this in some cases of atypical CLL. It always performs cytogenetic testing, including FISH testing for translocation 1114. This is to rule out mantle cell lymphoma because the leukemic non-nodal variant of mantle cell lymphoma can present very similarly to CLL. And then, of course, the physical exam and your history for B symptoms are very important as well. Imaging is not always required for all patients, but really should be prompted by symptoms, physical exam findings, or lab abnormalities. Since we're talking about relapsed refractory CLL, I do want to highlight that if there is a concern for Richter's transformation or more aggressive CLL, then a PET CT should be performed if there's high SUV lesions with a biopsy of the most FDG avid lesion.